This video has been funded through an educational grant by Sanofi Ltd. Sanofi has had no input towards the content of the video or the interviews. Cold Agglutinin Disease is a rare, complement-dependent disorder affecting between 5 and 20 people per million. Its diagnosis can be complicated by the intermittent, temperature-dependent symptoms and overlap with other conditions such as Raynaud's disease. Dr. Jeremy Lorber of Cedars Sinai Medical Center spoke with us about his professional experience in education and treatment of the condition. We started with outlining the clinical signs and steps towards receiving a diagnosis.
In terms of the diagnosis, it is and it isn't straightforward. It's straightforward in that it's a series of blood tests, but what's not straightforward or more difficult is actually thinking of CAD, knowing about it to start the process. If you don't know about CAD, or even if you may know about it, but it's not top of your mind when seeing a patient, you're not going to go down the diagnostic pathway. So the difficult part is just thinking about it, having on what we call our differential diagnosis, and then ordering the tests. One common key feature of CAD is anemia, low hemoglobin, low amount of red cells, and that is very common for many, many reasons. And CAD is probably the 50th or more lower down common reason. So it presents like many other diseases. There are some key features both on the blood test and patient's history that should tip somebody off to think of CAD, but often that doesn't happen. And the main feature, anemia, just looks like other things like iron deficiency or other forms of hemolytic anemia that are more common than CAD. The two most common manifestations, if I put them into buckets for patients, are cold agglutination related symptoms. So that's symptoms that a patient may notice when they go into cold temperatures, change in color of their hand, ears, nose, parts of the body that are more cold exposed. But also, the other category is anemia. So that is not something a patient may necessarily see on their skin or have pain, but it would manifest more like severe fatigue, weakness, decreased exercise tolerance, sometimes lightheadedness. And those two buckets of symptoms are somewhat managed differently. The cold symptoms, yes, avoiding cold is important. Um, Anemia, cold avoidance may have some role in that, but we often, both for symptoms that are not controlled by just simple cold avoidance, which is not always possible depending on where a patient lives, there are different medications that we use to manage CAD. It's a disease that is chronic but fluctuates. So patients can be fine for long periods of time, have exacerbations where they have much more severe anemia. They can have severe anemia that's not getting better and needs treatment. So it's not a gradual buildup. I would say you're in the state you are at the current time, and it doesn't necessarily predict how you're going to be in terms of better or worse, a month, 6 months, a year down the road. It's somewhat unpredictable, even in terms of seasonality. Is that it's an autoimmune disease. So basically, that means that our body is producing antibodies, which are normal to produce, but in this case, inappropriate antibodies that are targeted not against a virus or bacteria, but against our own red cells. So we have a antibody, which is a type of protein that binds to our red cells. And the reason it's called cold agglutinin disease is because these antibodies bind to red cells at temperatures lower than our normal, roughly um, 98.6 Fahrenheit temperature. And then the disease is called cold agglutinin disease because these antibodies, when they're bind to red cells, cause the red cells to stick together. The antibodies can connect, basically, and that's called agglutination, where you have a clump of red cells stuck together. Um, the other part of the disease is the hemolytic anemia part. So these antibodies, when they're attached to our red cells, can activate what's called the complement system, which is part of our immune system that normally would hopefully destroy bacteria. But when it sees one of these abnormal antibodies stuck to a red cell, it activates and it basically punches a hole in the red cell and destroys the red cell. Destruction of red cells is called hemolysis, and that's why CAD is a hemolytic anemia disease, in that it destroys red cells, causes us to become deficient in red cells. Um, not part of the name cold agglutinin disease, there's also inflammation. So the activation of the complement system is an inflammatory process. And that, in addition to just the anemia, can cause fatigue. So inflammation itself from complement activation can lead to fatigue and various other symptoms. And it's thought to be related to why CAD is associated with a higher risk of long-term blood clots, thrombosis.
What kind of health risks does long-term CAD cause?
The long-term risks of CAD are there's some association with blood clots, what we term venous thromboembolism. It's somewhat controversial of how much risk is from the CAD versus just some incidental finding, but there is a thought that blood clots are an increased risk. And then for patients who have severe CAD, especially without proper treatment, um, chronic severe anemia is going to cause a decreased quality of life. There are risks to repeated ongoing transfusions over time if that's what a patient is requiring. Um, but it's usually somebody whose CAD was active, not inactive, and then ended up having some severe event. I mean, if somebody has a confirmed diagnosis of CAD, should always have some specialist following them, even if the CAD is not very active. At least an annual checkup to check hemoglobin and hemolysis markers, and to be there if something were to become more active. But symptoms that a CAD patient needs to be aware of, a severe change in their energy. So, a lot of people are fatigued, but if there's some obvious change from somebody's baseline, that may be a tip off that their hemoglobin has dropped and they're having more hemolysis than usual and may need an intervention, whether that be a blood transfusion or a change in medication that they're getting to treat their CAD. Um, in terms of CAD, there's also a long-term risk of venous thromboembolism that we worry about. That's blood clots. So swelling or pain in one leg may be a tip-off that one is developing that. And then CAD is manifested by, discoloration, pain in different parts of the body. But discoloration, or what's called an ulceration, which is actually kind of disappearance of skin that's not improving, should be something you tell your physician immediately about. Things that improve when you warm them up, that you don't need necessarily to run to your physician about that.
What treatment options are available, and how do they affect CAD patients?
Yeah, so beyond cold avoidance, the two main categories of therapy that we use are either what's termed B cell directed therapy or complement directed therapy. So, B cell directed therapy is typically done with a drug called rituximab, either by itself or in combination with a chemotherapeutic agent. And the aim of that is to kill the type of white cell that is producing the antibody, the abnormal antibody in CAD. So that's why we call it B cell therapy, because it's trying to kill B cells that are causing this issue. That is an infusion. Rituximab is an infusion that's given at varying schedules, but it's usually given for several times, usually 4 to 6 times, and then a patient is observed. The other category of treatments, and really the main approved treatment by different drug approval agencies, is something called sutimlimab, or the brand name in the United States is Enjaymo. That is a complement directed therapy. So that's directed not at the B cell that's producing the antibody, but at a part of the complement system. The complement system is part of our immune system that is meant to kill different viruses, bacteria. But in CAD, it's abnormally activated, and it plays a role in destroying the red cells. So sutimlimab aims to stop or halt that process of the complement activation.
How do these immune modulation treatments change the rest of a patient's well-being or health behaviors?
So there are a couple different ways to think about this question. In and of itself, CAD is not immune suppressing condition. So CAD should not increase somebody's risk, at least typically, for an infection. However, looking at it the other way, routine infections that we get, colds, flus, urinary tract infections, any type of infection can exacerbate CAD. Um, these conditions, infections, activate the normal part of our complement system. That's the part of our immune system that helps fight infections. But the complement system is also abnormally activated in cats. So any complement activating condition, like an infection, has the risk of exacerbating CAD. And then CAD, like I mentioned, is not in itself immune suppressive, but some of the treatments that we give for CAD can be immune suppressive. Rituximab, chemotherapy, sutimlimab, which is a complement mediated agent and actually has a warning for certain types of infections while on that therapy. Those all can increase the risk of infection. So even though CAD itself doesn't, the therapies that many CAD patients are on can increase the risk.
What kind of research is happening around CAD, and can patients be a part of it?
CAD is a rare disease, and because it's a rare disease, there are limited products that are approved or that have good data. We're lucky now that we do have some, even though it's a rare disease, but still, compared to more common diseases, the treatment options are limited. So, for many patients, clinical trials are appealing. They give a patient a chance to possibly have a better therapy than what already exists to manage their disease. It also provides the broader CAD community and physicians who treat CAD a better understanding of the disease and hopefully the development of better options going forward. Rare diseases are hard to recruit for clinical trials just because there aren't many patients who have them. But if a patient has an opportunity to participate in a well-designed trial for CAD, I always encourage it. In oncology, there's, especially for less common cancers, there's a concept called the basket trial, which includes more than one type of cancer. That way, if one particular type of cancer is quite rare, you'll still be able to recruit to a trial because you'll have a collection of rare cancers. So together, they make up an adequate number of patients for a trial. You need a certain number to prove if a therapy works or doesn't work. Um, for CAD, the same approach has been taken. Several clinical trials recently are what we call basket trials, which include not just CAD, but patients with other diseases. So, basket trials are one way for a rare disease to still have a useful clinical trial and possibly better therapies going forward.
How much ongoing education is needed for healthcare practitioners and patients around diagnosing and treating CAD?
Is unfortunately, a lot of times patients are left to learn about the disease themselves, but that's not ideal. Ideally, the physician treating the patient should give the patient an accurate overview of CAD, what it is, how it causes problems, what the problems are, and then not just a general overview, but where the patient falls within the disease. The disease has different manifestations. Some patients have more severe or less severe disease. Some patients have more of one type of problem than another and may benefit from different types of therapies. So it's important for the physician to individualize the education for the particular patient that's in front of them. One problem, I do encourage patients to, learn on their own, but one problem is not just inaccurate information that a patient may find on the internet, but sometimes information is accurate but not pertinent or correct for that particular patient. Um, so, a patient may learn about a particular therapy and everything they learned is correct, except for the fact that it's not appropriate for their case. So, the physician should do that. Unfortunately, because CAD is a rare disease and many patients are being followed by physicians who don't have a good awareness of CAD, they are left to their own education.
What would you like patients to know about how clinicians manage CAD that they might not be aware of?
Patients need to recognize that, at least as of today, there's no cure for CAD, even when they have an effective treatment. Um, we think that there's still some risk that a patient can relapse or have their disease problems recur. So I always tell patients that this is a long term partnership. I still, even if a patient's doing well, still recommend at least annual checkups. And then some therapies, like the complement directed therapies, they work while you're on them. They inhibit complement and prevent the anemia from CAD, but they're not going to work when you're off of them. So again, it's a long-term thing, and patients should understand that it's not, hey, take this for a month or take this for a week and you're done. This is a long-term disease that has its ups and downs, and they should still be vigilant, even when doing well, that something could change. A lot of patients think, because these symptoms they didn't have earlier in life, they develop maybe at age 60 or so, which is roughly the average age of diagnosis. Um, they think, well, this is a temporary thing, like an infection or some other disease, it will pass. But unfortunately, even though people aren't born with it, and it's what we call acquired, once you have it, the risk that you're going to have exacerbations is high, and it should be followed and treated as appropriate. It should not be ignored, or treated with, just over-the-counter supplements, iron, folate, which I've often seen, which is often inadequate for management of CAD.